Damage control surgery, DCS, is a surgical strategy primarily used in trauma and emergency settings to address life-threatening injuries in critically ill patients. Its primary objective is to stabilize the patient and manage life-threatening conditions rather than definitively repair all injuries during the initial operation. The focus is on preventing the lethal triad of trauma: hypothermia, acidosis, and coagulopathy. TASH. Concept of damage control surgery. The philosophy of DCS revolves around the recognition that a critically injured patient may not tolerate prolonged surgical procedures due to physiological derangement. Instead of definitive surgical repair, the focus is shifted toward 1. Rapid control of bleeding, hemorrhage. Stops ongoing blood loss using techniques like packing, vessel ligation, or temporary vascular shunting. 2. Prevention of contamination, temporary control of injuries to the gastrointestinal tract or other sources of infection. 3. Temporary closure, the use of temporary abdominal closure techniques such as vacuum-assisted dressings or plastic sheeting to minimize further physiological compromise. 4. Stabilization in the intensive care unit, ICU, correcting coagulopathy, restoring blood volume, optimizing oxygen delivery, and managing hypothermia and acidosis. 5. Definitive surgical repair, delayed reconstruction. Once the patient's condition stabilizes, they return to the operating room, usually within 24 to 72 hours, for definitive repair of injuries. Indications for damage control surgery. DCS is typically indicated in patients with 1. Severe trauma, massive hemorrhage from abdominal, thoracic, or pelvic trauma. 2. Physiological compromise, hypothermia, core temperature 35 degrees Celsius. Acidosis, pH 7.2. Coagulopathy, prolonged prothrombin time, activated partial thromboplastin time, or low fibrinogen levels. 3. Time-sensitive situations, when prolonged surgery would exacerbate physiological derangements. 4. Multi-system trauma, patients requiring simultaneous management of head, chest, or extremity injuries. NASH phases of damage control surgery. 1. Phase 1, initial surgery, control bleeding, e.g. use of clamps, packing, contain contamination, e.g. temporary repair of bowel injuries. Temporary abdominal closure. 2. Phase 2, resuscitation in ICU, correct metabolic derangements, warm the patient to correct hypothermia, manage coagulopathy with blood products or clotting factors, optimize cardiovascular and respiratory status. 3. Phase 3, definitive surgery, return to the operating room after stabilization, definitive repair of all injuries, closure of the abdominal cavity or other surgical sites. Benefits of damage control surgery. 1. Reduction in mortality. DCS has been shown to significantly reduce mortality in critically injured patients. 2. Improved physiological recovery. Allows the body to recover from the initial shock and stabilize before undergoing definitive surgery. 3. Adaptable approach. Can be tailored to various types of trauma, e.g. abdominal, thoracic, pelvic. CHASH. Challenges and complications. 1. Open abdomen management, risk of abdominal compartment syndrome, difficulty in subsequent closure due to tissue swelling or loss. 2. Infection, increased risk of sepsis due to delayed definitive repair and open wounds. 3. Prolonged ICU stay, requires extended monitoring and care, increasing resource utilization. 4. Long-term morbidity, patients may have long-term complications such as hernias, adhesions, or chronic pain. Recent advances and innovations. 1. Improved hemostatic agents, use of advanced hemostatic agents and dressings for rapid bleeding control. 2. Temporary vascular shunting, newer techniques for managing vascular injuries temporarily. 3. Enhanced critical care protocols, better resuscitation strategies, e.g. massive transfusion protocols. 4. Technological advances, use of imaging, e.g. CT or ultrasound, to guide damage control strategies. Conclusion. Damage control surgery is a critical tool in modern trauma care, emphasizing staged management of injuries to improve outcomes for critically ill patients. While it has revolutionized trauma surgery, it requires careful patient selection and multidisciplinary collaboration to minimize complications and maximize recovery.